Hello, a pleasure to be with you today for Class 2021. We are going to start the Medifacos conference by addressing a very important topic, scleral lenses and above all the scleral SG lens. My name is Bruno Lima and I am the area manager for Latin America at Medifacos, and I will be here to show you today a lens that has brought many benefits to patients with ectasias. Firstly, I want to make a historical summary of the sclerals worldwide. It began with Leonardo da Vinci in the year 1500, and over the years they evolved, and in 1950 the first scleral lenses were manufactured using PMMA. And when the scleral designs they came out onto the market, they were incorporating more and more technology and more technologies to treat the corneal irregularities. And so, in the year 2000, there was a growth and a expansion of the concepts. And this is a very important moment because the market was increasingly looking for a more practical and a more safe solution. And so in 2012, Medifacos officially introduced scleral lenses in Brazil with the Esclera lens. And in 2016, we launched the Optimum XC mini scleral lens for regular corneas, and in 2019, we introduced the scleral SG lens. Above all, sclerals were designed for the most difficult and challenging cases, with complex ametropia, keratoconus, ectasias, post-surgery, and in order to increase comfort in cases of dry eye and other syndromes. Some points that we must always consider about sclerals. The first is hypoxia, interference with epithelial renewal, conjunctival prolapse, nutritional deficiency of the cornea, and the increase in intraocular pressure, a manipulation of the lenses by the patient, and, of course, the cost. And so let's talk directly about Esclera SG, which brings us a great novelty in the design of the fitting set lenses. It has some very interesting properties. For example, the microcircles that the fitting set lenses have and are going to allow us to observe where we need to make the changes, as we will see throughout the presentation. As we can see here in the central area, we can increase or decrease 200 microns without modifying the base curve of the lens. The same can be done with the intermediate area or in the limbal area. And we are going to observe the area by area, what changes we can make and what the benefits are. The characteristic of the mini scleral lens has a diameter of 15.7 millimeters and can vary from 15 millimeters to 16.5 in 0.1 millimeter steps. Furthermore, there is one very important point to state, that this design allows all possible adjustments, and so it is a changeable lens according to the need of your patient. Another very relevant feature of this lens is the toric, or the toric front periphery design. This is a very important statement because in about 85% of cases the sclera is toric, and so you are able to have a toric periphery, which is allowing for a comfortable and able adaptation. And the toric design allows you to correct up to 7 additional diopters of astigmatism. And this is fantastic, which provides greater comfort for your patients. Regarding the control options, we can see, as I have already mentioned, that both in the center and in the other areas we can make adjustments with a very interesting benefits, and we do not need to spend additional time with the patient to make central or limbal area adjustments. As often we needed to enlarge the diameter of the lens, now it is no longer necessary. You are only able to make a limbal adjustment, or you can now change the inclination or the angle of support, which in turn it brings greater comfort and a more adequate adaptation to your patients. Again, on the trial lens, we can look at a very interesting point as seen on screen, which is the zones. These alternating zones tell us how much and where we can change. And because of this, all of the lenses in the fitting set are marked with a number to establish whether the test is being carried out with lens 1, 14 or 21. And this allows us to establish which lens it is and where we can do the adjustment. There are 5 steps that we normally must take in order for a professional to collect analysis of the patient to make an adequate adaptation for them. And so the first is to evaluate the apical or the sagittal vault. The second is an evaluation of the limbal fit. However, only a few lenses on the market have this possibility to be able to do this. The third is to evaluate the scleral support, and that shows us how the lens lands on the sclera. The fourth point is the elevation of the edge. If it can be lowered or raised, how much, why and where. And the fifth point is the over-refraction. And so let's go step by step. The first topic, many times practitioners ask me, Bruno, what do we do? Do I look at the topography to see what lens I'm going to start with? How am I going to start my job? We have a considerable number of parameters, and for sclerals, an initial analysis can be done by the topography, but it is necessary to know how prolate the ectasia or the keratoconus is to choose the ideal lens. And so then we know which lens to start with depending on how prolate the cornea is. And so this is the first step we must first take. The vault. The history of scleral lenses brings many fears about the vault. When we started, we talked about 400 microns, and then the lenses descended, and things have changed a lot, especially gas permeability. We at Medifacos only work with Contamac material that has a fantastic DK of 180 that allows us to manufacture a scleral lens that provides safety to your patients. And so, as long as you buy a Esclera SG lens, it will have Contamac material. The second very important point is that the design of the Esclera SG does not settle much over 50 to 60 minutes. And so what we have been able to observe over the 3 years that we have worked with is that the lens it settles 100 to 150 microns at the most. So to not find a final lens, I must have an initial lens with 250 to 300 microns to get to have 150 to 100. The issue is always in large congresses, with great panelists, opinion leaders, who talk about this issue of oxygenation. And they will always talk about this issue. And that is why the solution of this lens, when a ring is presenting touch or a partial touch, I can change this area and offer a much more effective solution. In other words, I don't have to change the lens for one with a larger diameter, because I can do a local change and, most importantly, introduce less material on the eye, achieving greater comfort with the safety of the design. The third point, which is rarely used by the market, but is a very efficient way of doing things, is the question of scleral support. The Medifacos lens comes with a 54 degrees scleral support that can be adjusted when too tight, up to 60 degrees, or if too loose, it can be lowered down to 50 degrees. And we can see how the variation in the angle of the support is made and how comfort is changed. How the way of landing on the lens on the sclera is changed. And when the lens is placed on the patient's eye, that is a fantastic variability, which changes above all the effect as in the figure that we are going to observe below. And so the scleral support should not be as in the third figure, where we observe a whitening that is cutting the vessels, not only at the edge, but throughout the scleral support. And so this modification literally changes the patient's life. The fourth point is the elevation of the edge. It is necessary to differentiate between the angle and the elevation of the edge. The edge should only be analyzed at the end of the lens, and we must observe if it cuts the vessels and does not enter the entire area, as we observed in step 3. And so many times we make a mistake requesting an edge change, and it is an angle elevation and vice versa. And that is why it is very important to observe the images that we present here in order to understand a bit more. There is a very important detail that Medifacos has, a help desk in Portuguese, in Brazilian or Spanish by WhatsApp, to which you can send a photo, exchange information, answer questions, because we are available during business hours to help you in your adaptations, no matter what your country is. The fifth step is the final refraction, and we have seen it over time. As we are celebrating our 50 years this year, we are celebrating the golden anniversary, and we are seeing that there is a very important issue. 48% of changes requested are due to an inadequate waiting time of the patient. And it is something simple. The minimum that a patient must wait is 45 to 60 minutes before performing the over-refraction with the trial lens, and so that the lens is fully supported and can descend it as far as it goes, so it is not to change the final over-refraction. Sometimes, patients stay only 30 to 25 minutes because a record is not kept when the lens is placed, to make the appropriate monitoring, and indicate to the patient that they must wait a few more minutes. If you want to understand this better, you can do a test doing a refraction with 30 minutes or 60 minutes. The toric periphery. As I mentioned, 85% of cases have toric sclera, and so for these cases, it is very important to also have a toric lens. That's why the trial set has 3 toric periphery lenses, so you can see how a toric periphery lens behaves for these cases and be sure whether or not a lens with a toric periphery is needed. That is why the fitting set presents what to do and how to do it. But one of the things that must suggest is the use of the toric periphery, and it is when there is a localized compression with whitening at 3 and 9 o'clock and a flattening at 6 or 12 o'clock. And it is necessary to add tissue. That is what the toric periphery does. Contrary to what we think, the toric periphery does not elevate the tight region, but does promote the closure of the periphery at 6 and 12 o'clock by eliminating excessive elevation in this region. About adaptation. In relation to frontal toricity, many times we are concerned about how much I should put, or what I am going to put, or how I am going to get this measurement. Many times we change the concept. However, if I have a toric sclera, I need to put a lens with toric periphery to know how much rotation there will be. Then, in the slit lamp, I must observe if this lens rotates in order to know how much front toric power I must request in this lens. Remember that when you are going to do the tests, we have the electronic resources by help desk, Skype, WhatsApp to propose a solution and support, especially at the time of fitting. And so we will be with you online and any time around the world. It is important that due to the toric periphery issue that we had talked about, that when we put the toric in front, this set allows that in any case in which the lens makes a turn, we can compensate it during manufacturing or in a detail, and it can be corrected up to 7 diopters. As I said, the conjunction of the toric periphery with the anterior toricity can be done and must be done to see how much the lens rotates and thus compensates for it during manufacturing. Sectorial elevation. This is an important issue, as often we see a small penguecula or a pterygium. Sometimes we simply can change the way of thinking and make a toric periphery. No. If there is a small penguecula, I must do a sectorial elevation. And as I do, I observe where it begins and where it ends, so I can have a level 1 with 150 microns, 2 with 250, or 3 with 350, obtaining a much more comfortable solution and a centralizing lens. I can do it on both temporal and the nasal side. Watch this video. Here we can see how much is changed at this time. With a very important detail. This lens focuses on its own and looks for how to accommodate according to where the sectorial elevation has been made. And so this is a Medifacus technology that is available in both the Esclera SG and the Optimum XC. Many times we are asked what we can do with a patient who has a very strong compression area in the 3rd quadrant, and there is a whitening in that area. For these cases, we have control by quadrant. We observe where it begins and where it ends, and unlike the elevation that is curved, a rise is made in a linear and straight way, and so it goes to the other point and goes down. In other words, this is one of the controls that can change many of the adaptations that we want to make the gold standard, but that does not allow them for X reasons. This adaptation is going to bring a fantastic resource for us. Inverse geometry. Who among us does not have cases of a post-RK or post-LASIK patient, a post-transplant keratoconus, that above the cornea I have a very flat center, and in this case I need to make an inverse curve to remove a pull that I have there, and so this lens enables us to do just that. Let's see how we do it. Note that in the center of a lens like this, we have a very large difference between the toric periphery and the sag. At this point, we observe the difference between modifying the sag and making an intense curve. And when we change the 200 microns ascending or descending, observe that the design does not change the sag height. Here, there is a very large difference, and we change the central curve to achieve the necessary reduction and remain as two shoulders that can help us if there is a lateral curvature in post-transplant cases. And so, all these videos are available and you can request them by WhatsApp. At the end of the recording is our number, and it can be your adaptations with these new designs. And so the inverse geometry, as we saw it explained in the video, is not only to lower the center, but also to change the curve of the center and move, and as we can see at the end of the central zone near the blue zone, to raise or lower the shoulders. It is very important because I can modify this area if there is not a touch by the RK. On the edge of the transplant, that is, we reshape the central area of the lens specifically for this patient. And so, there is a reverse act for a patient like this. On the markings, a toric periphery lens has all three markings. The front toric, both, and obviously a lens with toric and front toric periphery comes with all four markings. We are going to talk about a material that has brought a lot of happiness to us and security throughout all these years. Optimum Infinite is a fantastic material, and we are very proud to tell you that throughout all these years with thousands of manufactured lenses, we do not have the problems that many others talk about. Gas permeability, as I mentioned at the beginning of the talk, such as hypoxia and other cases. This is a very highly reliable material that has brought us great joy for being the first and only company that has it exclusively for all of Brazil. The Contamac company rewards us with a material like this because it gives us a lot of security to work with a product like this. The HydraPEG treatment, a very important point, and it is a treatment that we do on the surface of a gas permeable lens that allows us to have a hydrophilic layer on top of a gas permeable material. The benefits are a cleaner lens throughout the day, a more wettable lens, more stable patient refraction, and patient perceptions of image in patients who have a lot of allergies are benefited with this treatment. And so a Sclera SG lens can be manufactured with or without HydraPEG, and it is a user option that is requested when ordering. For this reason, in all these issues, Medifacos is present in more than 60 countries, with Latinos, with the Brazilians. We are very strong on this issue of special lenses, because we believe that our mission is to bring patients the best vision possible along with the most advanced technology, and providing professionals with the tools and training to find the best solutions for their patients. Here at Medifacos, whose slogan is "Vision is Evolution," we always look for the best technology. And we are present in all communication platforms with channels on YouTube, Facebook, Instagram, and we have, as I have already said, a service platform through WhatsApp, and I make myself available to you through my WhatsApp for whatever you need. Discussion of cases, explanation of solutions for their patients, exchange of information. It will always be a pleasure to have them with us in Brazil, in the company, so that they can learn about all this work carried out during 50 years. For us, it is a pleasure to have participated in CLASS 2021, the largest online contact lens event in the world.